Delahanty, did I pronounce that correctly?
Delahanty.
She's a nutritionist with us this morning. Of course, Marty from Manchester, Missouri, Dr. Michael Bloch, we heard him. So, we've got to make this entertaining. It's a real challenge because we don't know where you guys are, but at least you're still here. So, any type of dances, any type of stories, what have you. Dr. Bloch looks like he likes to dance.
I do. Turns out I like to party. I do.
Very good, very good. So we're going to party up here. That's what we're going to do, just to send you off in the right mood. I have a couple of announcements before I start. Two very important people, maybe they're still in the audience. Alexander Gary has walked 62,928 steps. That's 32 miles. 60,373, 28.5 miles. Now, they're the ones that are ahead right now. Maybe some of you have some more miles, so there's still a chance to go out there and win those prizes. Right now, these are the two leaders, so that was that announcement. The other announcement is the 2014 registration. Today's the last day of the discounted rate. And you see the dates, I think it's October 10 and 12. And it's going to be at Caesar's Palace. So I hope that you'll think about coming back. If you want to get that discounted rate, please register today. So what we're going to do, we're going to take some of the take-home points of all the plenaries primarily. Look at them, maybe, and then make some remarks, and get some interaction going with us. All right, so. What is this one here? Develop, individualize, that was learning materials. I want to get that. Okay, what's the take-home points? All right, here's the take-home points for the cardiometabolic quiz. It involves more than one element, da-da-da-da-da-da. And that's mine. That was my talk that I gave. And it's really, I think we know that it's a team sport. It's not just looking at hypertension, or hyperlipidemia, hyperglycemia, obesity. It's looking at all of them together because it's the accumulation of them that leads to the endothelial dysfunction. So, anybody want to add to that? Dr. Bloch, you want to add to that?
Sure. It's something I think that we've heard mentioned throughout the conference, but something that we just somehow don't highlight enough as we talk about the individual components and the different medications that we use for individual components of cardiometabolic risk. But the concept of primordial prevention, I think, is one that as public health practitioners we need to really think about. Secondary prevention, obviously, is making sure that people don't have a second heart attack, second stroke. Primary prevention is taking people, like we've been talking about all weekend, who have risk factors, and treating those individual risk factors so they don't develop their first heart attack or stroke or heart failure. But I think really the concept of primordial prevention is also an important one that we don't touch on enough. And that is preventing those risk factors in the first place. By really getting to people who have not yet developed metabolic syndrome, but who have a family history of doing so, who may be starting to gain some weight, maybe having other unhealthy health habits, getting to them when they are young, before they want to see healthcare professionals, and really recognizing that this is a syndrome that is not only treatable, but is also in many ways preventable through lifestyle modification.
Very good. Marty, I want to key off on your last talk and about it's not about numbers, it's about the patient. Well, let's look back. This is about numbers. We're telling you got to take care of this. Whereas really, I take care of diabetes, get your A1C down. So how do we get this concept across? But make it patient-centered.
I think you need to talk about my numbers, and to me about my numbers and what they mean to me in terms of my future health. So it's not just we know, this number is good and this number is bad. It's, here's what I'm concerned about for you. And those are the messages. There was an interesting study where this was about 20 years ago, they had physicians counsel patients about smoking. And they write a prescription. That was back when that was a big idea. Well, when they interviewed people who had those conversations and they said, are you going to quit smoking? And the vast majority said no. And when they said why, it was because, well, he said smoking was bad, but he didn't say it was bad for me. So part of that is the me message. We all listen to the world on WIFM, what's in it for me? And it's taking those numbers and then making them very personal for me. Not just I care about the numbers, but I care about them because of what could happen to you in the future.
Thank you, Linda. So, I think I got a DASH diet for this, and I got a cholesterol diet, and I got a diabetes diet. Well, do I just take them individually, but I got a patient that's got all that? Or they got all together? Is there one conglomerate diet?
Well, yeah, if you were people that were there this morning, my argument would be the conglomerate diet is to simplify and to help people focus on losing weight and reducing their calories. And, within that, you can see how many fruits and vegetables they're eating and see how closely they align with the DASH diet because there are health benefits. But if somebody wants to lose weight and is interested, then I would start with the weight loss because that, to me, that one focus covers a number of medications for each of the elements of the cardiovascular risk profile. If they are successful with weight loss, they could be avoiding one pill maybe for arthritis pain, another pill for hypertension, another pill for diabetes, and so forth. And it's sort of getting the most bang for your buck, so to speak, to focus on the weight loss. Now again, if they're not motivated or it's not a good time to lose weight, then you don't want to give that message. And more along the idea of the DASH diet or the Mediterranean diet, which are very similar in their recommendations, I think is the way to go.
Okay, we're talking about weight loss. You and I hardly had this discussion at lunch. And you discussed it somewhat this morning, the Look Ahead study. I think the Look Ahead study, some people interpret it as weight loss doesn't matter anymore for diabetes. Is that a misinterpretation of the Look Ahead study?
Yeah, that's really hit my Achilles heel hotspot because one of the issues I'm most distressed about in terms of the messaging about the Look Ahead study is that people are just looking at the headlines to say, okay, both groups had low CVD event rates. One group had low CVD event rates with less medication, and the other group had a little more medication, but there was no difference in either one. So basically, we're doing a good job. Well, that's a true conclusion. However, there's a lot that happened in that 9.5 median years of follow-up for patients that is getting lost in the translation. For instance, improvements in mobility, reductions in knee pain, improved quality of life, improvements in sleep apnea. Some of these things can't be treated with a medication. People don't like using a CPAP machine. And just recently at the June American Diabetes Association, some other results which haven't been published yet were reported. The lifestyle intervention group had less reported retinopathy and lower incidence of kidney disease. And so, again, the fact that the lifestyle intervention seemed to help glycemic control, like some of the other trials, the microvascular complications, while the macrovascular were different, seemed to be better with the lifestyle. So there's still more to come. Also, they reported at this meeting fewer subsequent hospitalizations for the lifestyle intervention group and less costs associated with repeat hospitalization. So there's a long list of benefits that are really not getting talked about. And the fact that there was also a new report of less incidence of depression for people in this diabetes distress that Marty has talked about. So there's a long laundry list of benefits that are sort of getting overlooked. While the bottom line is true, there was no difference in the CVD event rates. Patients were really much more happy, much more control of their destiny, so they felt, and those things are really important to patients.
So if we looked at the control group, usual care was pretty damn good care. It wasn't like they were just out doing willy-nilly. So that's one of the things I think we have to look at in the Look Ahead study.
Well, yeah, if I may too, just to amplify that, I know that it's technically did not meet its primary endpoint, but that's a successful trial as far as I'm concerned. In fact, we always wonder, could we lower cardiovascular event rates with lifestyle modification as well as we can with our medicines that have side effects? And in general, we did it in the Look Ahead studies. Patients had few cardiovascular events without taking as much medicine. That is the strategy that the majority of my patients want to take is, can I limit the amount of medications that I can take and still have low cardiovascular rates? And I think that study shows that you can, that if you add diet and exercise, and it doesn't have to be that much, really, if you look ahead, what's actually done with these folks, that you can decrease the number of medications that you're taking and still be safe.
So weight loss is still good, and lifestyle change is still good. I'm gonna move this on. Here's a little, you want to have another one? Go ahead.
Well, I just want to say that one thing that other people don't realize too is that the usual care group, they were privy to the results of the trial as it went along. So at 1 year, the results were reported. They heard that their counterparts in the intervention were getting really good results with weight loss. At 4 years, they heard the results of their counterparts doing really well. So they weren't blinded to what was happening, and many of them sought other treatments on their own, and that's why at the end, they had a 3.5% weight loss overall because they were trying to lose weight in other ways and get help from other sources.
Yeah, they didn't gain weight, which the average American with diabetes gains about 2 pounds a year, so they were clearly not a usual care group.
Okay, I'm going to say something a bit controversial, Michael. I don't know if this is your slide or not, but you certainly were the limit.
Sure.
Now, I'm going to make a controversial statement first.
Okay, go for it.
You know, I'm not sure LDL particle numbers are useful. And the reason I say that is I think they're overused. And I think we have underused guidelines and overused guidelines. I don't know. To me, I have non-HDL, and that's a very powerful tool. If I use it, a lot of people don't use it. I've got my lab test in front of me. I think 99% of my patients, if I was to have a non-HDL, I'm fine, and I can use that to look at residual risk. So what do you say?
I would not disagree with that. I'd say the number is more like 80%. That you don't need to look at it. I think that the key is that you need to be looking at something that looks at somebody's overall risk or overall atherogenic load. That we have recognized that LDL-C is not the only answer. And I think where all of our guidelines, the International Atherosclerosis Society, American Diabetes Society said, first what we got to do is we got to identify cardiovascular risk. If you have cardiovascular risk, put them on a statin. And then once you start thinking about where you want to treat somebody, I think treating an LDL-C to goal is necessary but not sufficient. And I think you need to look in another way at overall atherogenic load. And I think there's 3 ways that you can do that. And without good studies that compare them, I think it's difficult to know which one. You can look at non-HDL, which is very inexpensive. You already have it there in front of you. You can look at LDL particle number, which I think may give you a better idea of what their LDL load is, but one of the problems with it, it doesn't necessarily capture the full atherogenic load in patients who have certain types of dyslipidemia associated with high triglycerides, because it doesn't measure those other ApoB molecules. And then you have measuring ApoB, which is probably, and measuring and targeting ApoB, which probably would be the best of all of those if money was not an object. Of course, money is an object, and I never measure ApoBs for that reason. So I think picking and choosing among those 3 in an individual patient, I think you got to look at something, either their non-HDL, their LDL particle number, or their ApoB. I can tell you, in 80% of my patients, I just look at their non-HDL cholesterol, and then there's about 20% that I will potentially.
So I've got my numbers looking perfect, including my non-HDL cholesterol. I've got my proper diet, etc. What value is LDL particle?
In that setting, I don't think it's any value at all. Where there is a setting, I think, is in those 20% of people who have a more unusual lipid panel. Somebody who has a very high HDL and a very high LDL, for example. Somebody who has a very profound tendency towards the metabolic syndrome may have a particularly small, dense LDL cholesterol. They may have a high triglycerides and a low HDL, but their non-HDL may not capture the totality of their number of LDL particles. There's also, for those of you who are in the case study that we went over, there are some patients who are discordant in the other direction. Some patients that are exceedingly healthy, like marathon runners, who will load their LDL molecule with a ton of cholesterol but have a very large molecule and few of them. They may have a high LDL-C and then a high non-HDL because of it. But when you actually measure their LDL particle, you see that it's low. So those are, I don't think we want to lose the forest for the trees or make the exception the rule. Those are a minority of patients where I find it to be a valuable tool. But I don't believe that it needs to be drawn and widespread use on everybody. Now when you think about it, it's a much more cost-effective strategy. if I'm limiting it to just 20% of individuals where I'm trying to drill down on their risk a little bit more, and I might want to do even more than that on those individuals. Those may be the same 20% of individuals that I'd like to look at a marker of inflammation. Perhaps even if they want to look at an imaging study on those few individuals. And once again, that's a much more cost-effective strategy than doing it on everybody. Did we find some area of agreement?
Say that.
Did we find some area of agreement?
Oh, absolutely. I just wanted to just get you dancing a little bit. You know, there is a. I still say it's 90%, but what's the difference? But we probably have a different patient population we see too.
I'm hearing Greg say that we are metabolically challenged.
Yeah. Okay. Marty, remember, you have any comments about LDL particle numbers? Are they, you know, it's again, you know, two doctors loving their numbers talking about it.
I'm just glad you didn't get into a fist fight.
Okay.
Yeah, I'm good with the discussion so far.
Okay, good. Let's look at some diabetes stuff here. All right. Here is the one, pre-diabetes. That's always a good discussion. Use of individualized risk evaluation allows you to determine who to screen for pre-diabetes. Screen for all patients with sustained blood pressure that's above 135 over 80. That's a good one. That's a good one. Should I screen all patients with 135 over 80? I'm not sure. 140, I was thinking I would, but just that number. Any comments, Linda or Marty, about that?
No, I don't disagree with you, but again, I think the other thing I would look at are some other risk factors. Do they have a very strong family history, for example?
Okay.
Because I'm seeing more and more thin patients who have a very strong family history. And they don't understand why they got diabetes, but you know, you had a parent and a grandparent on both sides of the family or whatever. So I look at family history as well.
So it's one factor. You'd like to have a couple other factors in there to help you say that's the screening, and I guess that might be a blood sugar or an A1C. Linda, anything you want to comment?
Well, I think, looking at more of a profile, especially if they are overweight and inactive, that whole profile together, and if they do have the family history. Just an aside, one thing that's really important to me is that even if people have a family history of diabetes, what we did show in the diabetes prevention program that the lifestyle intervention trumps genetic risk in terms of developing diabetes, so that, you know, screening them, and even if they do have that family history, knowing that they can take control of that.
Michael, I ask you maybe then, talk about the blood pressure with that, and look at that third bullet point. Identify patients with pre-diabetes may improve long-term micro and macrovascular complications. Would you want to discuss both those bullet points?
Sure. You know, I think that, you know, clearly we tend to like thresholds in Western medicine. We like to say, yep, above 140, we're going to screen you for pre-diabetes. But at 135, no, it's not necessary. You're only pre-hypertensive. You know, what a person's blood pressure is today versus what their blood pressure is tomorrow can be vastly different. And so I think really it is, as my colleagues have said, you know, really looking at the totality of that patient. If their blood pressure is a little bit high, but they don't have any other cardiovascular risk factors, you know, I think we need to follow their blood pressure carefully. They need to be making lifestyle changes that are going to decrease the risk of developing diabetes regardless if they're in that pre-hypertensive range. But I would have a very low threshold for screening for checking fasting sugar, you know, any family history, being overweight. You know, I think the question of it's more almost a philosophical question about whether or not we need to identify patients with pre-diabetes. And if part of that is how effective do you think education can be with your patients, right? If it turns out that patients look like the control group in the diabetes prevention study, and that they're not really able to lose, they're told they should lose weight, but they don't do it, and they continue to eat the same way that they've eaten, then identifying that they have a condition that they're not going to do anything about is not going to be helpful. However, if they're like the look-ahead population, which I don't have diabetes, but if they're teachable, or if we're good teachers, then I think we can show that there would be, or we can hypothesize that there would be benefits from identifying pre-diabetes. You know, when I go to our diabetes education program, I help run it, and I'm shocked by how many people say that they had no idea that they were developing diabetes. I hear that all the time. You know, out of the blue, happen to have the blue. You go back and you look at their sugars, and they had that hypertensive state. I'm sorry, pre-diabetic state. And, you know, if you ask them, you say, gosh, wouldn't you want to know that? Would you have done something about it had you known? They always say yes. Now, whether they would have or not, and whether that would be a good use of our healthcare dollars, I think is a different question. That's why this borders on philosophy in some ways. But I think knowledge is power. I think you want to know if somebody has pre-diabetes, and I think they should know if they have pre-diabetes.
It's interesting, what's the ICD-9 code? It's not pre-diabetes. We have to use a different ICD-9 code for that. And the reimbursement is an issue. But Lynn, do you want to say something else?
Yeah, since I was involved with the Diabetes Prevention and Program study, we were recruiting for that study. We had these thoughts that people wouldn't be interested in doing a treatment for a problem they didn't have yet. And we thought we were going to have a lot of trouble motivating people to actually do all these things when they didn't yet have diabetes. And exactly the opposite was true. People came in and said, I don't want diabetes. They knew somebody, they had a family member, and the motivation was so powerful to do the lifestyle intervention in that study, and I would say even more, having been in Look Ahead as well, even more powerful than in Look Ahead. Because there's a certain resignation that I notice in people with diabetes. They already have it. They say, okay, I already have it, maybe it's going to help me be on less medications and these other things that are important. But the power was in really not ever getting it in terms of motivation to change behavior. So we saw that in spades and we were surprised.
Let's talk a second a little bit about the anti-obesity drugs. And, we had Dr. Ron gave us the talk this morning, but what do we think about that, Are these of value? With that, are we fooling ourselves? The last big wave of obesity drugs, we went down the road, we're on the way with them. So, I know you guys don't prescribe the drugs, but what's your feeling about it?
Well, I think that they can be of value, but it's very important that people don't think that it's a replacement for doing a healthy lifestyle and being active. And many patients think, just like when they take a pill for diabetes, that the pill is taking care of everything, and that they don't need to pay attention to lifestyle and activity. And it's really important to emphasize that they need to work together to get an enhanced effect.
These medications really point out that, as do many in chronic disease, the importance of shared decision-making and involving the patient in that decision. And not only that, helping to manage expectations. None of these pills will help you lose 100 pounds in 2 months. So we need to help people understand that it's not magic. It's not magic, and it's to help people get started, lower their risk for some of the health problems. If I want to get back to my high school weight, fit in a bikini, this pill isn't going to do it in a month.
Okay. Mike, any comment?
I agree very much with that. I think they have a role. Weight loss, I always say weight loss trumps all, right? Any way you can get somebody to be motivated to lose weight, that's the fuel of the fire of metabolic syndrome. But we have to recognize there are some trade-offs potentially in terms of side effects, and we have to know how to use the drugs. And just like you said, I think you said better than you did, patients really need to understand their limitations and the fact that this is for a set period of time while we make other changes. And sometimes I will use the analogy of, not to mention brand names, but some of the prepackaged diet plans where you get your food in the mail. It's sort of the same thing. Those work while you take them, but if you don't change what you do afterwards, you're just going to put the weight back on. And so I try to counsel people about the medicines in the same way. We can use this to jumpstart, use words like that. I sometimes we use it to push somebody off a plateau, because that can be really frustrating for people when they've lost a good amount of weight and then they tend to plateau. I think a better way to get off that plateau is to kick up your exercise a little bit, but sometimes it is a matter of your metabolism slowing a bit, and these things can help nudge you a little bit or help motivate you or a patient a little bit. But I think it takes a lot of time to talk to patients about these medicines. And I have to say that in my practice, it's one of the reasons that I don't use them as much, is because I know I'm in for another 10 minutes conversation. Because it really is hard to have. It's a tough and involved conversation. It's not as easy as, hey, here's another blood pressure medicine, because I want to get your blood pressure down 10 minutes. So it can be difficult.
I found it interesting that one of the future medications with liraglutide, Victoza, a 3 milligram, because I find, 1.2 nauseates enough of 20 definitely does. they're probably going to barf themselves on the way home. So that'll be interesting to see how well that turns out. That'll be interesting to do that. Talk a little bit about bariatric surgery in the last few minutes here. Just, you know, we heard Dr. Ryan this morning. What's your experience with it? Has it been good? Is it something? I worry with the more extensive surgical procedure, the death rate. That was a lot of people. And Dr. Peterson tried to ask me this morning, you know, if you have 90 billion people and it's a 2% rate, that's a lot of deaths. So what do you guys think? What's your experience? We'll start with you because you probably do the nutritional counseling for those people.
Well, I always like to make sure that people have really tried a lifestyle program and not just a diet before they feel that they failed diet. But the truth be known is there's some people, I had a person in the looking at study. He was in a lifestyle intervention and he got all those resources and help, and he just had a family environment that was sabotaging, and his wife had already had bariatric surgery, and he just couldn't lose the weight and sustain it and sustain the skills. He had too many distractions and stresses, and he just decided, you know what, I don't want to be on this much insulin. My kidneys are going down. I feel like, you know, I'm on a bad track for my overall health. He says, I just want to do this. And so he did, and I just talked to him last week. He's lost 70 pounds, and, you know, has all these health benefits. But I do worry about the death rate and the complications, especially when I've built an 8-year relationship with this person in the study. But so far, you know, he's faring okay. So I think it is important for some people because they just really have tried and they're at their wits' end that they want to lose weight.
And you're talking about probably the BMI is 40 plus,
Right.
And or the complications like that, diabetes, renal. Okay, so great. Marty, your comment?
I think too, I hear people say, oh, he lost weight the easy way, he had surgery. And I think people have this perception that I have the surgery, now I can eat everything I want, but I'm not going to gain weight, I'm going to continue to lose weight. And people don't appreciate that your life has changed irrevocably, almost with some of these surgeries, other than the lapping, which you can't undo. But that it's not the easy way. That there's a lot of work. It's a lot of lifestyle change even after the surgery because you can't eat like you used to. And so it's not the cure-all that people would like to think that it is. I also, on the other side, though, know a lot of people who are terrified of the surgery because of the publicity around famous people who've died. And so I think we have to be realistic in what we tell them, but also it's not that necessarily won't happen to you that the surgeries have gotten better.
Okay, good.
And so I think we need to give a back. You know, it's like everything else. We need to be balanced in the information. So our patients are making informed decisions based on facts, but also based on what they know about themselves.
You want to make the closing remarks?
Sure. If I could say about bariatric surgery, I agree with that very much. I do think that when I look to keep the complication rate low, you should know your surgeon that you're sending these folks to, and they should be able to tell you what their complication rate is. I want to have 2 questions for my surgeons that I do bariatric surgery. Number 1, what's your complication mortality rate? And number 2, what is your post-operative dietary intervention? How often you see him, what you do, what supplements you tell him to take, how often do you see him? And I think that's really incredibly important. And I loved the presentation about getting primary care providers more involved in that post-bariatric care. Because people, I know the guys in our town are really great about following up with patients, but people move, and people don't want to establish with a new bariatric surgeon when they move to a new town. They don't have had their surgery. They want to establish a PCP, but who's knowledgeable about the specific medical issues, as you mentioned, straight one set of issues for another. It's the specific medical issues that are associated with having had bariatric surgery.
Well, wonderful. We've used our time. You guys have been great. Round of applause for you and for us. We'll see you next year.